Wolmark, and welcome to the CRUK Cambridge Centre podcast series for another Ask Me Anything episode. Today I have with me some of our wonderful patient representatives from across the CRUK Cambridge Centre PPI groups. I have Lorraine, Frankie and Anne, and I also have some ICM researchers who are based at the University of Cambridge. I have James Brenton, Ines Machado and Gabriel Funingana to talk about AI in healthcare. We'll talk about ideas and thoughts and concerns about the use of AI, and we'll get the patients to quiz our lovely researchers as to how they're using it currently and perhaps where they see the field developing in the next few years. So first of all, I'm going to ask everyone to introduce themselves. So Lorraine, let's start with you.
My name is Lorraine. I'm a ovarian cancer patient, but I'm also a cancer trial survivor. I was diagnosed with stage 3 ovarian cancer and I'm 5 years with no recurrence. I'm associated to the PPI Women's Cancer Group, and I'm also in CCRH and PAG, and I volunteer for everything so that I can give my wee bit back for people who help me survive and be here where I am today.
Lorraine, that's wonderful. I'm just going to tell our listeners CCRH stands for the Cambridge Cancer Research Hospital and PAG stands for the Patient Advisory Group. Thank you, and we're very, very happy to have you with us. Anne, tell us about you.
Hello, I'm Anne. I'm a cancer survivor. I had colon cancer 16 years ago and bladder cancer 11 years ago. And I'm a trial survivor as well. I've been involved in research because I was very interested when I was a member of the trial, patient member of the trial, just what research was all about and so on, and I got hooked onto it then. But I've been a member of the PAG, the Patient Advisory Group, since it's in session, started however many years ago now, so a long, long time ago. I'm also a member of the Independent Cancer Patient Voice, ICPV, and I'm a member of the CAM Centre Executive Board and also a member of the Cambridge Institute Strategic Advisory Board as a patient advocate.
Brilliant. Great to have you with us. Thank you, Anne. And Frankie, tell us about you.
Hello, I was a cancer patient a few years back, and I'm a member of the PAG and on various groups within that, because I fill in when they've got gaps. So I'm on lots of different things. And I'm also on the Learning from Death Committee for Addenbrooke's and the consent group. So various other things outside the specific cancer one.
Brilliant. Thank you, Frankie. Great to have you here too. And then my researchers, we've got Gabrielle. Tell us about you.
Hello, my name is Gabriel Funingana. I'm a medical oncologist and a clinical research training fellow, part of ICM and ovarian program. And my main research is about improving patient stratification for personalized treatment in ovarian cancer.
Brilliant. Thanks, Gabrielle. And James, tell us about you.
So, hi, I'm James Brenton. I'm a medical oncologist and a researcher. I lead a laboratory focused on ovarian cancer in the Cancer Research UK Cambridge Institute. And with Maria Crispin Atuzo, I lead the ovarian program in the university.
Thank you, James. And Ines, tell us about you.
Hi, my name is Ines Machado. I'm an engineer by background and currently a research scientist at the Early Cancer Institute, the University of Cambridge. And I work with James and Gabrielle on developing computational models to help treat cancer patients.
Thanks, Ines. So thanks everyone so much for being here today. The first question that I have is, what do you understand by artificial intelligence? So Anne, let me throw that to you. What do you understand by that term?
Very little at the moment, I'm afraid. Yes, just in terms of hearing from the media, all the dreadful, scary stories that we hear about it. And I think really I'd like to ask the question a little bit differently. Is artificial intelligence already being used by the 3 wonderful research people we have with us today and others that they know of, their colleagues and so on? So I'm hoping to find out a lot more about it other than looking at it from a patient point of view, from the academics point of view.
Brilliant. I'll just ask our other 2 patient reps what they understand by AI, and then I'll throw it open to our researchers to give you some answers, hopefully. So Lorraine, what do you understand by AI?
Well, again, like Anna, I don't know very much about it, only what you read in the papers, but when it was briefly explained to me, I think it's a good step forward to getting people their diagnosis a bit quicker. That's my understanding of it. And anything that's going to help patients getting diagnosed quicker is a plus for me. So that's how I understand it.
Great. And Frankie, what are your thoughts?
Quite a few. I think AI can be very, very helpful and very, very unhelpful. I don't think we know enough about it at the moment. So I'm on the fence with it. I think with certain diagnoses and things and straightforward things, it's going to be enormous help, and the clinicians will know where it's safe. I don't like the idea of AI saying, I don't agree with James Brenton on that. I think I know better, and that worries me, because where does it stop? So I suppose I'm a little bit further into it and a little bit more worried.
Okay, brilliant. Thank you for setting the scene. So, James, as you have been mentioned, let's pass over to you. What does AI mean to you?
So I think, like many of these words, it has a lot of jargon and misunderstanding about it. And it's often used in the same sentence as machine learning, deep learning. And essentially, what all these terms are trying to get over is the ability to analyze very large amounts of data and find patterns, and to be able to use those patterns in effective ways for analyzing new pieces of information. And that process usually involves quite a lot of statistical analysis and having high quality data sets. And as we'll talk about later on today, there are other complexities in true artificial intelligence approaches that I think Ines and Gabriel will talk about in more detail. But at its heart, it's really a jargon word that really means, well, we can use some form of computer learning, which is usually statistical in basis, to actually analyze complex situations, such as, what does an image look like from someone's radiological examination, or what's the meaning of this genome profile that we've got from a test that we've done in the clinic. Just to finish this, I think that there's a lot of hope from many of us that this will help bring up the quality of care and the options available for patients with ovarian cancer, because it could help bring expertise to more patients and new discoveries that might help them.
Yeah, absolutely. And perhaps then I can throw open Anne's question, or a variation, I think, of Anne's question to Gabrielle, which is, what do we mean by the use of AI in cancer research and patient care? How do you use AI now? Because we know, well, I think you're using it already, to Anne's point. And what do we not mean? So we don't mean a robot doing a surgery, for example. There's still a human being involved. So yeah, what are your thoughts on that, Gabrielle?
As mentioned by James, we probably mean AI also to do with machine learning or some form of algorithms that are used to make sense of big data. So in terms of that, I already use it because my main research is on whole genome sequencing, which comes with a large data. And we need to find patterns that are linked to biological processes that are meaningful in order to be targeted or to inform the treatment. And in order to make all those patterns evident to us, we use some sorts of algorithms. So those could be quite basic. So there are some based on rules, or could be more advanced, where we come to actually have deep learning methods that will do all these patterns extraction automatically. So in that regard, this is already deployed to clinical use. But on another hand, I'm using AI also as a research tool, because there are other areas where we are trying now to improve the extraction of those patterns. And because, we sometimes depend on the human factor for some of the patterns extraction, and we can't go and ask, for example, a radiologist to look at all the disease sites in all the tummy to find whether in all of those sites we have cancer cells. Sometimes we prefer to automate a model an AI model that will help us to extract that from the images.
And that's just to do with time. Is that right, Gabriel? It would just take an awful lot of time for the human being to do that by eye.
Yes, it's time, and also it could be that could sometimes be more precise than us, which is still an area that we have to understand if it's correct or not.
But once the algorithm had done that segmentation, that automation, it would then the patient's care would then be given to a human to decide the treatment. So the AI wouldn't be deciding the treatment. Is that right?
Yes. So at the moment, those tools are mostly research tools. So they are not deployed in the clinic. And we are still trying to understand how successful they are and how accurate they are. And before they don't pass all these thresholds, all these tests, they will not be actually used in the clinical practice. So there is like a long journey from developing these research tools until they become decision support tools that are going to be used in the clinic.
And can I just ask about the data, which I think James mentioned? Is the data sort of looked at or I don't know, examined in terms of the AI? I've still got this sort of a feeling of a little bot that does it, but I don't suppose it is. But I need to visualize a something. And so is that as well as people like yourselves looking at it and other researchers, or instead of, or do you look at it after it, whatever it is, looks at it? I just can't get in my head, how all of that literally works.
I can speak if on my behalf. I will give the example of genomic analysis. So we have to look at the entire genome. We have so many genes that might be affected in cancer, or some that might actually be not entirely affected, but reported as affected by this pipeline. So if we go back to how the data looks, that's a lot of like letters in the DNA that have to be analyzed. So if I will do that manually, only to read one DNA molecule from one patient will take me years. So therefore, the machine will actually flag up exactly the regions of interest where I should go and look at what are the defects or the changes that I have to analyze. So some parts are automated because the machine will do the reading. But if I don't trust the machine, I will bring those kind of readings from the DNA up on my screen, and I will look to see exactly if the machine was right or not. And this will apply to other types of data. So machine will do some sort of automation. They will look at this data in a different way that we can look at. But whenever we feel we want to actually test whether it's right or wrong, we actually bring it up on our screen and look for those patterns.
So is it a little bit like looking for a needle in a haystack? The machine does the looking for the needle, and once they've found the needle, you then examine the needle to see what's happened. Is that a good analogy?
It could be the needle in the haystack, or could be the noise, or like to try to actually find the right tune from the noise. So whether we have some data that is not accurate, is not making sense, and might waste our time, and the machine can automate the filtering part of that data. So could be the needle in the haystack, and also could be the cleaning of the data.
Frankie, you look like you want to say something.
One of the things that concerns me, I suppose, is that you use huge amounts of data that an ordinary person couldn't go through, but we still have to trust the truth of that data and the truth of your algorithms. And at that level, I still don't understand, because the data could be skewed in that certain people don't put forward their data. How do you balance that? How do you manage that?
So we're just discussing what this means in practice. And I think it's important to say that the AI that exists in your web browser and is often associated with large language models has some useful functions. And most notably, because the algorithm has built this large web or network of knowledge, those mathematical tools can do some tasks really well. So for instance, you can take a complex document and get an online AI tool to quickly summarize the main points. And I can see that's going to be very helpful in, for instance, the legal profession or in many aspects of business where you've got to get through a pile of documents. And what you want is that artificial intelligence to quickly summarize things for you so you can then concentrate on the things that are really important.
Mm.
And notably, of course, if you asked it to summarize something like a PhD thesis or a scientific paper, it'll tell you what the paper says, but it doesn't give you added value. It doesn't say, well, at least at the moment, it does say, well, this question was asked in the PhD work, but actually it's been shown elsewhere that this, and this happens.
Mm-hmm.
So that kind of summary function, using very large quantities of data from the web and published literature and other things, is here now, and people are using it. And I think that that's going to be very important for trying to be more efficient when we're prioritizing our work. As was being discussed a few moments ago, I think that in the research setting, if we have the right types of data and the right quality of data from patients with ovarian cancer, we can use similar approaches that are currently researched at the moment to look at all the complexity, in other words, all the differences that make it hard to really understand for an individual patient what their imaging means, what their genomic tests means, what their other blood parameters means, what the appearance of their cancer down the microscope means. But by consuming very large quantities of that sort of data, we might be able to see patterns that can be recognized by an algorithm that have very specific outcomes. And of course, that would need validation and testing. But we could then see situations where, in a way that I was trying to make this comparison of the legal profession and lots of documents, you could imagine an MDT then not necessarily choosing treatment based on the algorithms, but understanding very quickly the key points they have to get to as fast as possible. And I think with medical advice and medical decision making, there's always some uncertainty. Some of it is always based around experience. But one benefit of that approach is you could make that experience, at least as a first pass, available to many more doctors, nurses, allied health professionals for what is quite a rare cancer and for where a lot of expertise is centralized in a few places in the UK, but is not so prevalent in, say, Lincoln or, smaller hospitals outside major centers. So for me, one huge advantage here is speed up in time and raising the possibility of much more equitable care and understanding, not necessarily the delivery of the care or the choosing of the care, but suddenly meaning patients get a better, faster opinion.
Does that answer your question, Frankie?
Yes and no. We'll get on to bias later and things like that.
Yeah.
Leave it for now, but we'll.
Okay.
Yeah. Yes, I understand what you're saying, and yes, I think that'll help. But I think we'll come on later to other things that I think are a problem.
Ines, did you want to add something?
Yeah, I just wanted to add that this question about what is artificial intelligence and why we are using AI these days to help treat cancer patients. So if you think about the definition of intelligence per se, for instance, it has to do with this ability of process information in order to inform some future decision. And what AI does is basically we train computers to do these tasks that normally require human thinking, like, for instance, learning from data or recognize patterns. And AI relies basically on three key main ingredients. So algorithms, and these algorithms, so particularly neural networks, they have existed since the 1950s. So they are not new. The thing is that data and access to these data sets has become more abundant than ever. And it's only in recent years that we have had access to this high performance computing that is needed to train these algorithms effectively on these massive data sets. And that's why these days we talk about AI and we use these AI models. And in our field, in specifically in cancer research, and a few examples of how we use AI, for instance, in the lab, is to help detect cancer early, for instance, to improve diagnoses, to support treatment decisions. And the reason we do this is that because AI can analyze these large amounts of medical data much faster than humans. Most of the time, it finds these subtle clues that might be missed otherwise. And this helps clinicians provide more personalized care to patients. So definitely what we don't mean when we talk about AI is that AI is going to replace doctors or to make decision on its own. So it's a tool to support healthcare professionals.
Thanks, Ines. Thanks for that clarification. We've touched on it a little bit. What does AI look like? Does it have a face? Is it a box? What does it look like? Ines, do you want to say?
Yeah, sure. So I think that AI doesn't have a single look because it's mostly software working behind the scenes. It can be a computer program that analyzes medical images or a tool that helps doctors predict patient outcomes. So sometimes AI can be part of, for instance, apps in our phones or devices like voice assistants or smart sensors. You may not see AI directly, but you experience its effects in faster diagnoses or better treatment plans. So I think that AI is often hidden in the technology that helps scientists and doctors understand the disease more clearly.
Okay, thank you. So I want to move on a little bit about the benefits of AI, thinking both now and in the future. So I wanted to ask you, what do you all see as the main benefits? So we've said speeding up diagnosis or helping clinicians to speed up, not use their time for mundane tasks, as it were. It can do the groundwork and then they can base a decision upon that. Is that the main benefit? What other benefits are there? Or do you think there would be potentially in the future?
So to me, there are, I think, different types of benefits. Some benefits that we are aware at the moment, and other benefits that we'll become aware of in the future. So the benefits that we are aware of at the moment are definitely the fact that we can automate, so we can speed up processes or democratize some of the processes. So for example, in breast cancer screening, we can do more mammograms for more patients because we can rely on an AI system that will analyze the mammograms, and then we can offer these to as many patients as we prefer, rather than being limited by the numbers of radiologists to look at those mammograms. And other ways of democratizing care is that we'll make sure, as mentioned before, everyone will have the same level of care in all the hospitals across the country. So we will not have only some expertise in one hospital, but that expertise could be actually made available to everyone else because we can transfer the knowledge from one hospital to another using these AI models. And then another advantage benefit that I see is, for example, accelerating our understanding of disease mechanism and drug discovery. So those are things that now takes a lot of time, a lot of experiments, a lot of resources, and sometimes they fail. So the rate of failure is quite high, for example, in drug development. And if we can, reduce the number of drugs that we test, or we have the right drug from the start, and then we accelerate the drug development, we might actually translate finding from the lab to the clinic in actually a shorter amount of time compared to what we do today. And then in terms of what are the benefits that we might not be aware of, it could be that we will be having a better, more holistic care of everyone. We will maybe prevent cancer rather than treat cancer. We maybe have more time to actually advise different people who might be at risk of developing a cancer how to actually live a healthier life, in order not to get cancer or other disease. So that's what I think would be the benefits.
Can I get some of our patients' thoughts on that? Lorraine, what do you think about what Gabriel's just said?
I never understood AI until I've been to these symposiums, and hearing it explained in baby steps, it really, really benefits the patient. But I'm a firm believer you're only as good as the team behind you, and as the information that's going in to give you all this data that you can then diagnose a person quicker, is that every researcher is putting in their information. Who's checking that? Just some things frighten me. Although I've got hope, and I heard James using that word hope, and it's hope that things are going to be better for the future. Because let's face it, cancer is a horrible, horrible disease, no matter what kind of cancer it is. And I think it's good myself personally. It is scary for people to try and understand it. But I thought what Gabrielle said was good. And I understood it.
Good. And did you have some comment that you wanted to make?
Yes, I mean, I agree very much with what Lorraine has just said. But for me, working recently in recent years with researchers from the lay point of view, they share information and so on, but everybody writes a paper and hopes to get it published and whatever. So just looking at it from the research point of view, is that going to continue along the same way? I mean, using the data and whatever else, as well as the end result, which we as patients are very interested in, of course. But thinking from a researcher's point of view, is there still going to be this sort of, I don't know, golden goblet that's going to be around somewhere for them to share their research earlier, or will it still take as long as research takes at the moment, or is that a variable that you can't possibly predict?
James, do you want to respond to that one?
That's quite a difficult, I think we have to be optimistic that AI offers benefits as well as downsides. And we've touched very briefly on the possibility of making the wrong decisions because of bias or because the data is not correct. And, what I am reassured by is that high quality research, high quality science has controls, it has validation. It doesn't just kind of enter clinical practice without, those checks and balances. Now, of course, and I think we'll talk about this, if I'm not mistaken, quite soon, but if you put the wrong data in, or you only study, white females from East Anglia, in terms of the patterns, then, that's not going to work in Soweto or Uganda or South Korea, or it may not work, but possibly, because I do think the East Anglian population has some interesting aspects to it. But so we do have to be careful, and often we're not as clever as we think. So, we there may be biases we don't know about, but that's all about testing real world data, high quality clinical and translational science. I think there's just a lot of hype, and I think I completely understand how that hype makes everyone feel uncomfortable. And for those of us who are sort of struggling to come to terms with what this might mean, and that includes myself, I try and avoid the hype. And a lot of this is applied statistics and just large data sets. And as Ines was explaining, ability to use advanced computing resources to be able to trawl through data that we simply couldn't do before, and do many, 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 many calculations across those data sets. So I'm half full, not half empty, but we have to be careful.
Yeah, I hope so. Can I just ask a follow-up? I mean, for patients, myself, I'm speaking for myself, but other people that I know, a relationship between yourself and your clinician is based on trust. And we go into hospital, we meet with clinicians, and we don't say, where did you learn that? And what data did you use? I mean, some of us might start doing that, but there isn't time to have that in the consultation room anyway. But I've just got this thing about how is we as patients going to say, well, do we need to know what data you've used for this? And how should we trust that? Or we're still just having the trust with our clinicians and so on? I think there's some work to be done there with patients to embed the fact that the trust is still going to be, or the relationship is still going to be between the clinician and the patient. And as some of us have already said, we've got our doubts, or we're hearing what the media wants to tell us about it, and all of that kind of stuff. So I'm not quite half full. I think I'm sort of about a quarter full at the moment, and 3/4 worried about that side of it in terms of a good relationship, so that you've got trust with people.
Yeah, I mean, as you might expect, I think that personal human interaction between patient and caregiver is really important. And as you highlight, trust is everything, and also ability to listen and to take nuances of information into account. Those are very difficult to reproduce by AI systems. So again, just arguing for the half full just for a second, I think the ability to quickly get through information for these systems to help us look after more patients at lower cost and overhead is a good thing. And I think you will always have the check and balance of human in the loop. I guess what worries me, if you think about many business models in service industries at the moment, so, in no particular order, Department of Work and Pensions, tolls on bridges, parking fines. Somewhere there's a human in the system, but those systems are set up very much to try and curtail any challenge or the opportunity to go back and disagree with a decision. And I very much hope and would argue strongly for a complete avoidance of those models as we move forward with AI and medicine. It's not about breaking this relationship. It's about making the relationship between patient and caregiver more productive. And to mean that the time you have is better, particularly if you were starting a clinic with 20 people in it and you didn't know very many of them. Even the existing large language models, the ability to quickly, and let's say for the sake of argument, you've turned up in a hospital, you've never worked in before, the ability to summarize the information so that you can then have a consultation that's much more efficient. These are big positives. But they don't take away from that importance of listening, understanding, intuition.
And the checks and balances that you mentioned, they'll be in place.
Absolutely.
Yeah. Okay. Thank you.
I'd like to come to Frankie because you've been nodding through that conversation. So tell us your thoughts, Frankie.
I agree with the, quickly to personalised treatments and all the rest of it. But we're doing it on the back of medics who've been there for some time and have worked through a system without AI. We're going to get a younger generation in who won't have done that. And so we've got a body of expertise, if I may put it like that, that hasn't relied on this. That's one of my concerns. Okay. The next one, I suppose, is the nervousness about the poor algorithm was used in examination systems, which I'm sure you all know about, that flared up. And none of us knew about that. And it was horrific and caused the most awful problems. So that actually has made people a bit nervous about the reliability. And also, at the moment, if I may call you James, you said something about to challenge it. I mean, if you get discharged and your discharge letter says you're blind and you're not, it takes 6 months to get it changed. So challenging anything at the moment in the health service takes ages, even if it's a simple thing, somebody ticked a wrong box. So as a patient, I'm a bit with Anne here. How do we know? I mean, I go in, I trusted Mr. Halder, he did whatever he did, he was brilliant, and it all happened. But it was based on him being the expert, him knowing what to do, and complete trust in, I trust consultants. I'm afraid I might be old-fashioned, but there you go. So with research, I think it's slightly different in that you're coming from a slightly different angle, and what you're basing it on is stuff that you believe and you've monitored and you've checked and you've double-checked. And the algorithm is there that Gabrielle was talking about. I have no idea where your algorithm came from or how reliable it is. So that's my bit of concern. I think in general, it's going to help us. And as Lorraine said, it's going to get us personalised treatment much more quickly. But I do think there are dangers within it that we don't know about yet. And I still think that one day your AI is going to say to you, Gabrielle, James, don't agree with you on this. This isn't, and you're going to have to sit there and say, sorry, but I'm the human, I win. Or will you? So, I mean, that's further down the line. Is that fair?
Gabrielle, do you want to respond? Yeah, go ahead.
So if I can take, so I think there are different parts here. So one about education. So how to educate newer generations of professionals, healthcare professionals, or any professionals in general, when some menial task might be taken over, so might be automated by AI, where more advanced tasks might actually still require some humans to actually perform those. But I still think this is down to us to decide how the educational system will look like, even in medicine. So I think we still need to actually have the same checks and balance of promoting going to the different levels of training. What AI can do is, or maybe improve our understanding. So even assist in our educational. So sometimes you might have different ways of learning, and you might have an AI agent that may help you with that. So that could be the positive. Definitely, there could be the negative if people rely too much on an AI system, and then, they will not be able to make their own decision. They will be biased by the AI system. And that's where we need to actually regulate very carefully. Then reliability of the system. I think, like was said, there are checks and balances in how any research is done. And also there are processes of drug approval, for example. And I don't see why. And I think these are the conversations. An AI system will go through the same process. So like a clinical trial, and will be used only for a certain population. So when someone will use that, a medical doctor or nurse or any healthcare professionals will use those systems, they could use it only in that specific setting. So whenever they interpret the results, they will say, okay, I can use this system because it has gone through the phase, all the clinical trial phases, all the approvals, and it's good for this, but it's not good for this setting. And it's the same when we prescribe a medicine. We need also to interpret the results of the trial in the right setting. So the trial has some inclusion-exclusion criteria. So the drugs might work only for a certain population or not for another. And then challenging the system, I think it might be that it make more difficult to challenge or more easier because the patients might be in control of their data, of their care. They will have access to the decision much easier than they have right now on their phone. They might receive the alert from the system. Your blood test has been, reported, and rather than the doctor needing to click to release the results, maybe the system will decide to release those, and you will be aware of the results much early on. So could be that, or could be that, depending on how it is deployed, could make things difficult. But again, this is where the regulation comes in and all the, discussions about ethics and application of AI.
So I want to go to Lorraine because she's just got something to say, I think, please.
I've got to say it while it's in my head or it vanishes. Is the AI information that the consultant in Somerset has going to be the same AI information that a consultant in Cambridge has? Is it a big, huge AI for the whole of Britain, or is it per trust? So you could be getting different information depending where you came from.
James?
Yeah, so well, and I also want to respond to Frankie's great
And Frankie's,
comments in a moment. So the first thing is, I think if we're going to understand a problem like ovarian cancer, at the heart of it is biology. The wiring diagram of that cell, the amount of cancer that an individual has, their other medical problems, perhaps their germline genetics, what they've inherited, how they handle medicines, it's genetically driven. All those things have to be taken together. And so I'm just conscious when we talk about AI that perhaps we're talking about this kind of AI that's more sophisticated than perhaps Gabrielle and Ines and I envisage in the next few years or even next decade. So right now, and this morning, Gabrielle and we sat with other very expert colleagues looking at whole genome data from a patient's whole genome. And that has a pattern, and that has a kind of a set of rules. And, I don't understand all those rules. And it's great to have that multidisciplinary team approach, understanding the maximum information we can get out of that. But I think that problem is is relatively straightforward to move to a decision support tool for the person in Somerset. And providing it's based around good science and good biology, I don't think it matters about, it's less subject to worries about ethnicity, patient population, because we're talking about relatively constrained space. Similarly, I think the analysis of when we start tying that information together with the appearance and organization of cells in the cancer seen down the microscope or seen with protein staining, then I think that's still a fairly tractable, meaning, can be addressed, can be relied upon, could be seen to happen in the next 10 years, could be trustworthy. And so just taking those two pieces suddenly brings up everyone's quality in terms of a decision. Now, whether we can, take detailed CT images plus these other information, plus possibly past medical history from a patient and find something new, I think that's an open question, and that would be much more subject to potential effects from where you are, what your ethnicity is, and other things. So I think we should talk about AI in terms of more like practical tools that are good at tasks that we understand already, not on tasks that we don't understand. And potentially, as we've talked about before, the discovery piece needs to be validated and checked and all those things. So I don't think at any point we're saying, we're going to take the human out of the loop. But I want to return to Frankie's great comment. So, like Frankie, so here we are talking about artificial intelligence, but actually I feel rather despondent about the intelligence levels of current systems and people's ability to use them. So, obviously we use Epic, which is I love. I think it's fantastic. But what I also know is that there's a normal distribution, in other words, a bell-shaped curve of abilities amongst my colleagues and the way they engage with it and use it. And in my heart sinks every time I see on someone's problem list, eyesight problems or hearing difficulties. And it frustrates the heck out of me if those things are left to persist. And even worse, if an individual says, well, hang on, this isn't true about me. Can you fix it? And no one fixes it. And those speak to all the problems about change management and culture and how we bring in change, which, we are doing in a moderately good way about some of the systems we have already. But if we're going to bring in decision support that might be more complex, will that be more difficult or easier? I don't know. But I just wanted to share the same frustration that Frankie has. I mean, the number of times I see patients who've already put in on my chart a request for their medication to be updated and no one's done it. That's just crazy. It's a few clicks, and the safety things are, medication, allergies, past medical history, problem list. These are the things we should be absolutely focused on.
Could I just add
perhaps we need AI to help doctors do that.
I just say something quickly. We were talking about greater access to information, so that the AI does it quicker and you get the information. I find my chart quite threatening because they send me through all my blood results or whatever, and something's 0.02 above what it should be. I'm in total panic. So I ring up a friend who's a GP who says, don't worry, if it's plus 2,000 worry. But I didn't know that. So I find access to that information actually quite threatening. Probably nobody else does because they understand it. But often you get the information before you get the consultant. And the consultant or the GP says, oh, don't worry, it's nothing. Whereas you've worried for 2 days or 2 weeks if you can't get a GP appointment. So I think there are also things about feeding to the patient what you're finding and who does it and when. So I think that's just something for you. Sorry.
No. I'm gonna pick up on this, Frankie, again. At a meeting, I was at a meeting last year, and I saw what Epic were putting in to help with my chart queries. So for those of you who are listening to this podcast, my chart is a fantastic tool by which communication can be improved, I think, between caregivers and individuals who are patients. And But a lot of people don't use it very well, and they're worried that it's going to take them a lot of time. So, I mean, we can talk about that in a different way. But so Epic are trying to bring in AI methods of automatically replying to my chart queries. And I looked at those and I didn't like them very much because they're a bit formulaic. And again, it comes back to what do we want to use AI for? Do I want to use AI for producing boilerplate text, which says, thank you for your query. Problems with sinusitis are usually this, which is fairly generic, or do I want to have better ways of structuring information? And I think it's obvious the way I want it to work. Regarding understanding of results, again, I think that at the start it obviously is very unsettling, but again, good communication should explain the concepts of normality and what should be expected. I mean, one of the things I learned from one of my patients about 7 years ago, she said to me, I'd rather have my CT result and cry in my front room than be sitting in the waiting room waiting for a result that I'm really dreading. And I think the way we use systems should be very much tailored to what patients need. Not everyone wants that, although I have to say none of the patients I see don't want their CT results, but the MyChart thing allows you to add a note to it so that you can say something personal about the result. But those things are tremendously transformative, and I think AI used properly will be transformative as well, because I'll be able to do more things.
The used properly is the thing that, with respect,
yes, of course,
is the worry, because used properly it'll be brilliant, but at the present time I would be with Anne half empty on that one rather than half.
I think as well, sorry, I can just say that I wouldn't want my chart or Epic or whatever to be another version of Dr. Google, giving that kind of information that we have to sift through ourselves, and we've got it. And just to follow on from that, the MHRI have got 5 key principles for regulatory use of AI, and they state that all AI systems should be appropriately transparent and explainable. So I'm just wondering how we can make this happen in that medical setting. And I think that's what you're saying, James. It's got to be made explainable and easily understood by people.
I wonder if Ines could talk to that, because she, is responsible for building these models. How do you make them explainable and accountable?
So one of my main concerns is that, of course, is ensuring that AI is used safely and fairly, and benefits patients without unintended harm. So what do we actually do in the lab is we try to continuously test it and monitor the performance of these algorithms in real time. So most of the algorithms that we developed in the lab, they were trained in retrospective data. So we know if a patient responded to treatment, we know if the patient had cancer. So these models have looked at retrospective data, but of course the ultimate goal is the deployment of these tools in clinical practice. And for that, we will always need to, as I said, continuously test it and keep monitoring the performance. And at the moment, how I see, for instance, the AI in cancer research evolved in the next few years is that at the moment we have these tools, and then the scientists say, I want a model to do this task. So I tell what is the algorithm that should be used, what is the data that the algorithm should look at, and then I train the algorithm and I have a performance. But we are not training the AI to actually solve the problem. So we are basically giving the model a recipe. Use this model, look at this data. So what we want to do in the future is to go into this direction of developing agentic AI, so to have some sort of like AI agents that communicate within each other. So ideally, what we'd like to do is to have a model that if we need something from this model, we allow the model to decide itself what is the data that it has to look at, what is the best algorithm it has to use in order to perform that task. And then you have some sort of like AI agents that communicate to each other in tasks that are considered low risk. And then they summarize all this information. They communicate this summary to the clinician. And then the clinician ultimately takes the final decision.
Thanks, Ines. That's really well explained. And James, did you have something you wanted to add to that?
No, I think Ines has done a great job in summarising that.
Okay.
Can I just mention as well that in the MHRI, they've got guidance that states that governance measures should be in place to ensure effective oversight of the supply and the use of AI systems, with clear lines of accountability across the whole life of the life cycle of AI. I'm just wondering what safeguards are in place at the moment, or do we think in the areas that we're looking at should be in place, and who's going to be held responsible? I mean, is there something being put in place? You're nodding, Gabriel, so that's reassuring. Thank you. Yeah.
So I can speak from our experience. So we are now implementing an AI model in Adam Brooks, and we are going through a evaluation actually study first before actually ingesting patients' data directly to the system. So one thing to actually highlight is that this system is developed by a company together with us, but when the model will be deployed in the hospital will be only on our premises. So the data will never leave the hospital servers. The model will come to the data.
Right.
So those are one levels of safeguards. The other level of safeguard is that in order to understand how the data is understood by the model, we will go through different steps and we will evaluate each of those. And then when the time will come and the model will be deployed in the next years, the other safeguards might be that, every time someone will come and check the model still works properly. So there will be some kind of metrics that will be measured and made sure that those are reaching the level of satisfaction that will allow the model to be maintained. And who is going to be responsible if something goes wrong? I think it's like in any medical decision, is a person who is taking that decision. So probably will be still a clinical team, so a medical doctor or the healthcare team that will be responsible. So the AI system will be another tool in our toolbox, will not replace us. So that's why the philosophy at the moment is that there is a man in the loop. So it's not something that will replace and will make the decision automatically. I think that conversation about AI agents that will be, making those decisions automatically without consulting a human being are way in the future. And we are not yet there. And then when we come to that, probably we'll still need to have another conversation to understand how to regulate that.
Frankie, did you want to ask something?
Just a couple of things. You said that the data would never leave the hospital server. What about the university from a research point of view? Because I know elsewhere we've got debates about the university, the hospital, the sharing of data. And that's just us not going to other parts of the country. So that was question one. And the second one was going back one. Will the directors of the hospital or the board will this be on their risk register as a general thing they'll look at? Is the monitoring and evaluation of AI.
James or Gabriel?
So let's deal with the risk register first. I think risks have to be specific. And I'm still slightly concerned that we're talking about a kind of amorphous AI thing that we haven't defined. So for any software system, for instance, the analysis of whole genome sequencing, we'd need to assess a risk, and it would be on an appropriate risk monitoring process. So again, I don't think we're there yet, frankly, in terms of, some of the concepts we're talking about aren't practically here in front of us. In the research setting, that's a different thing, of course, because it doesn't have any impact on patient care. The question of data sharing, we have, of course, in terms of confidentiality and pseudonymization, those things are well developed. But I would just say that I think that a lot of what we're talking about here has now made doing translational research very challenging. Not what Frankie's talking about, but the culture that we live in now with a real concern about whether governance or the law is being broken, particularly about GDPR and what's happening, is really, really being interpreted in variable ways between institutions. And that's harmful to patients and harmful for research. For the avoidance of doubt, I'm not arguing against regulation or good standards. I'm saying that in a very risk-averse world where we don't have a lot of expertise, what's happening is high quality research is just taking a lot of time to get consent for an agreement. And I think that that's everyone on this call, patient groups, consumers, consumer advocates, consumers relations, need to put input into this, because we're just heading to a mire of a lot of bureaucracy that actually is now harmful to trying to move things forward. But that's not specifically about AI. I'm talking about, can we share data and put data on a clinical study if patients didn't consent for data being accessed, pseudonymized data accessed internationally? And some of those things we need to pick up on another podcast. I think that would be really helpful to think about what those challenges are.
The consent thing is really, because when you sign it, it's for Addenbrooke's, say, but then researchers in the university might want to use it, and there's got to be an agreement there. And then we hear they might sell that, I don't know, to the Chinese or to somebody else, because they've got, and I think the consent bit, which is, again, I'm involved in at a very low level on that seems to be a minefield as well, which I think hinders your research.
And again, for the avoidance of doubt, I'm not trying to take consent away from patients. What I'm talking about is structures that say, oh, well, because this wasn't discussed in 2010, you shouldn't be allowed to do that, without a way of saying, well, what do patient advocates think? What about ethical approval? Is it, if we took it back to patients now, are you listening to them in terms of what their views are about what should happen to data? And, we should follow what patients want that happens to their data. It's not very much against a paternalistic view, but the world has become extremely bureaucratic and risk averse, and it's really harming the ability to help good research.
So I'm aware that we're short on time. This has been an absolutely amazing conversation, and I do agree it'd be great to have you all back to do another podcast, a deeper dive perhaps into some of the elements that we've discussed today. But can I sort of finish up with thinking to our patients, have you been involved in developing of AI tools? Have any of the tools impacted you directly? How would you like to be involved, and how can we work together to sort of raise awareness of the good and the positives as well as the risks? So, Lorraine, let me start with you.
Well, I'm Mrs. Positive, so I would be happy to help with anything. But I'm just wanting to go back. Do you think my question was answered there regarding data protection when I was asking about the information the AI is given to a consultant in one part of the country is the same information that a consultant's getting the other side of the country? And is that what you were talking about, James, like data protection, and you can't put it outwards? I'm asking as a person that really doesn't understand it all. And I was just getting a wee bit confused there, so I was just wanting to see.
I'm sorry, my fault. I'll just say it in a different way. My feeling is that where we're in the near term, we're talking about AI being able to understand things that have a biological basis, and therefore I think we could be sure that the same information is transferable to Southampton or Scotland or
that's what all of us
somewhere else.
Want to know. Yeah.
In the constraints around genomes, pathology imaging. As we get beyond that, I think the explainability question would become very important, as was highlighted by other discussants. I think, yes, I do think in the near term. Thank you.
That's explained it for me. Thank you very much. And yes, I'll help, and I'll come again. I don't mind talking about anything that's going to help patients in the future.
Yeah, and I think it's really important as well that, yes, we come back together, us and others, obviously not just ourselves, but having been involved in, when I was working professionally, in having a bespoke HR system designed for me. I mean, the IT people took it off and did wonderful things, but then they didn't do certain things. And then, of course, they said, well, you didn't ask for that 6 months ago or whatever. So you've got to know an awful lot more before you can tell the IT people. And I know we're not necessarily talking about IT people, but when we talked about Epic and My Chart, they come up with all sorts of things, and it's not really, it's like that diagram we used to have about when children wanted a swing built hanging from a tree, and what the architect designed and what the marketing people designed and all of that sort of thing. And what the kids really wanted was a rope hanging from a tree. So I think we just got to be careful at these early stages that how many months or years, whatever, down the line, we didn't do the basic bits to get that right. So that's what concerns me.
And Frankie?
Just a couple of things. I mean, all the way through, Gabriel, Ines and James have talked about it's the early stages and it's years ahead. I think the speed of the development of AI is even going to shock you who know much more about it than we do. And therefore, I think in a way, I don't know how you stay ahead. That's one challenge to you. How do you stay ahead of that? And the other thing is, and I'm chanting this everywhere, we must always remember there will always be some patients who, for whatever reasons, do not have access or understanding with IT, My Chart, smartphones and everything else. And therefore, we must always have another way of gathering information rather than, oh, we'll send you an email and you can do it on that, or do it on your app. And therefore, we're leaving out quite a few people in the population who don't know either what you're talking about or can't do it anymore because they've got, I don't know, Parkinson's or something. And those are probably the people you might want to get at, because they might get cancer. I mean, they're not going to get it, are they? So I think that's just something I keep saying, have a parallel system somewhere. So when everything breaks down and there is no Epic, there's something on paper somewhere for someone. Is that reasonable?
I think this question of accessibility. So until recently, I was vice chair of clinical research committee at CRUK, and this is a really important question about realizing and reminding everybody that not every patient has a smartphone or an internet access. And if we fail to remember that, we will not be reaching everybody, and also that we may miss things that are very important because we've obviously got a biased population. But at the end of the day, it's very important that there's equity in information access. So couldn't agree more with those statements.
Thank you.
Thank you.
Gabriel and Ines, any final words?
So I want to say about my phrase of unknown unknowns. So we might think that we know everything, but there are certain areas that we are not even aware that we are not knowing. So that's where I think we should invest, and I think will never be replaced in that understanding by any AI system. And even if there are a lot of developments, and maybe they are very, rapid in promoting those, I still think there is a lot of real stringent thinking, deep thinking that has to be done in order to understand how to deploy these systems. And some kind of, common sense principles will never be replaced by any AI system. And that's why I think being aware about these unknown unknowns and the biases that all of us might have is important. And that's why all this development has to be done in a multidisciplinary approach, including the patients advocates, because they might make us aware of these unknown unknowns. So those are the last words from me.
And Ines, anything from you?
Yeah, sure. So I think that AI is definitely not going to replace researchers or clinicians. I think instead it's a tool that helps us work more efficiently. It handles large amounts of data and highlights these important patterns. And I think that the expertise, the judgment, the compassion of doctors and scientists are definitely irreplaceable and very much essential for delivering the best care and making meaningful discoveries. So I think that AI will definitely support our work, but will not take our place. Thank you.
Thanks, Ines. And I think on that lovely note, just it remains for me to say thank you so much for everybody for being here today. It's been a really interesting conversation. I feel very calm that you're all involved and that we're getting all these important ideas and thoughts and feelings together, and that we can work together as a team, researchers, patients, everyone together to make sure that the systems are safe and that they get to impact the patients where they're most needed. So thank you so much for joining me this afternoon. Thank you.
Thank you, everybody. Thank you.
Thank you, Ellie.